Thanks very much. First, I'd like to start by thanking the organizing committee and the co-chairs for the kind invitation to come here. I am a speaker who represents the Canadian College of Neuropsychopharmacology, past president from many years ago. And I just wanted to say that I'm very impressed by this meeting, by the enthusiasm, attendance, and quality of the speakers. And I will be working hard to try and see if we can do something about a joint meeting between the CCNP and the TAP in future years. So this is a slide of some aspects of where I live. Depth of winter and the height of summer. Quite a nice prairie city, fairly close to the mountains. Disclosure, there are no conflicts of interest in terms of financial commitments in relation to any of the work provided, and ethics approval was obtained from the Human Health Research Ethics Board at the University of Alberta, clinical approval from Alberta Health Services. So alcohol use disorder, the previous speaker is talking about prevention and binge drinking. We're quite interested in brain changes in abstinence. I'm going to say a little bit about the effects of naltrexone, but not much about that. Two questions we're all interested in addiction. What's a healthy brain look like, and what happens to the brain in addiction? Researchers who've worked on this, my colleagues, Dr. Tim Gillese, Professor Serdar Dursun, who's in the audience. We have a great research nurse, Marnie McKay, and a computational neuroscientist, Matt Brown, and a lot of other people on the team, including some people from the Mannheim Institute with Wolfgang and colleagues, and some funders. Always good to recognize that. So this is what the brain used to look like. We're a lot more optimistic these days. We have really good windows on the brain in terms of neuroimaging techniques. I'm going to talk a little bit about behavioral constructs related to addiction. I'm going to pick particularly risk and impulsivity in relation to neuroimaging. And I'm going to talk a little bit about the clinical study we've been doing as part of the CHARMS-ARC project. So magnetic resonance imaging is probably familiar to all of you. We use a 4.7 Tesla magnet, fairly large high field magnet. Very good for non-invasive diagnosis, prognosis, and understanding of disease. And of course, MRI measures of water in tissue, can be used for a number of applications. Anatomical, functional, we can measure iron, sodium, cortical morphometry, wiring through DTI, perfusion, and metabolites with MRS. We're focusing on fMRI today. We've done some DTI measurements, but I'm not going to report on that. And fMRI really relates in our use to blood oxygen level dependent changes, indirect index of neuronal firing. Tractography is wonderful. The DTI stuff that's referred to really lights up pathways in the brain. We have some of those data, but I don't have time to present them to you today. The neuroimaging center we have is very well appointed with different scanners, using lots of different techniques, and we have a new PET MRI system which will be in place in 2016. So risk, impulsivity, and addiction. Behavioral constructs generally relevant to addiction are decision-making and risk-taking. These really echo some of the constructs spoken about by the last speaker. Impulsivity and response inhibition, and reward and craving. We have done some work developing a neuropsychological task that we call an emotional go-no-go task that really looks at the independence of decision-making, go or no-go, and emotional distractor stimuli. And with this task, we can actually measure independently the influence of an emotional distractor and response inhibition processes. So this is a basic setup. In the two upper panels, you can see a go stimulus. So there's a square in the middle of each panel, and that's go in this case. And in the bottom two panels, there's a no-go stimulus, which is a circle. So if you see the circle, you have to withhold responding. If you see the square, you have to respond. And we can alter the attribution of these stimuli. Importantly, in the background, there are emotional stimuli. On the left, there are neutral stimuli, a table in this case. On the right, an aggressive dog. And we found that we can use this test to look at the effects of emotion and look at response inhibition processes independently. It's superior to some other tasks because here's an example from Savanka paper in Alcoholism, Clinical Experimental Research 2014. The go-no-go task is an emotional one, but the emotional stimulus is the go-no-go. You cannot take emotion and response inhibition away from each other. They're confounded. So using this independent stimulus task that we published back in 2012 with fMRI, we were really interested in the relationship of brain activity reflecting emotional context and go-no-go performance respectively. And we correlated fMRI responses to risk measured by the Cognitive Appraisal of Risky Events scale, or CARE, and impulsivity measured by the Barrett Impulsivity Scale, a short form. Risk and impulsivity are correlated, but most people don't talk about them as different constructs. If you think about it very simply, you could be somebody who likes to take risks, but you wouldn't have to be impulsive to do it. It's a very simple explanation. On the other hand, you may be impulsive, but you may be afraid of risk, and so that fear may modify your tendency to be impulsive. So they do correlate. We wondered what would happen. Looking at the analysis of the go-no-go or inhibition aspects of fMRI versus the risk scores, we found relationships between risk and response inhibition in three areas: the right orbitofrontal cortex, the ventromedial prefrontal cortex, and the right occipital cortex. So you can see that with the orbitofrontal and ventromedial, there is a decrease in contrast as the score increases. In the occipital cortex, there's the opposite relationship, showing that these changes are quite specific and the correlations are quite good. There were no relationships between fMRI changes in these regions and impulsivity scores, and that surprised us. Conversely, in the dorsomedial prefrontal cortex and in the perigenual anterior cingulate cortex, there was a relationship between emotional distractors and impulsivity, but no relation to risk scores in these regions. So these data may be important because they may really indicate a dissociation between risk and impulsivity, which are important components of psychological processes that may determine maintenance of addictive behaviors. This is a summary of the positive and negative correlations between response inhibition and brain regions and the emotional distractor and brain regions. So we looked through the literature to find if there are any other dissociations like this. We couldn't really find much. There's a lot of discussion about motivation and impulsivity and risk these days. Trevor Robbins and others have written quite a lot about it recently. But we found one report that dealt with nicotine dependence and a behavioral study looking at the Barrett scale and a different risk scale, the BART, a balloon analog risk task. And they reported a positive relationship between nicotine dependence and impulsivity, a negative relationship between dependence and risk. So we think that differential correlations in this context show that risk and impulsivity might be dissociable constructs, and so there may be separate processes going on in brain that might be accessible in terms of understanding the phenotype of people who are at risk for addiction or may have more difficulty overcoming addiction. If we look at brain pathways and decisions related to reward value, it turns out that from a number of groups, a small group of specific brain sites encode subjective values for rewards on a neural common scale. And associated with this common representation is a subregion of ventromedial prefrontal cortex and orbitofrontal cortex, which are two of the regions that we observed. And this is taken from a paper by Levy and Glimcher being famous for establishing neuroeconomics. And here is a diagram you can see, and the color-coded numbered areas, 1 and 2 are the ventromedial prefrontal cortex and the orbitofrontal cortex, also prominent are the dorsolateral prefrontal cortex and the insula. So here we have right orbitofrontal cortex and ventromedial prefrontal cortex in relation to risk, being quite interesting as they're part of that core set of structures in that circuit. So, are brain regions that exhibit differential correlation to risk and impulsivity relevant to decision-making in addiction and during abstinence? We're interested in brain changes during abstinence from alcohol, and we're interested in regional dissociation effects for risk and impulsivity. So as part of a study, we've looked at alcohol withdrawal and abstinence in relation to brain function. Talking to David Nutt about this, I had to put David's very impressive slide up from his Lancet paper in 2010, which shows on the far left that alcohol really is the biggest drug problem we have. You've got orange or red, harm to others, and blue or green is harm to the users. An example of how bad the situation is taken from one of our hospitals in Edmonton, from a convenient sample of patients coming into emergency who agreed to do a computer score test. 43% reported active substance abuse. Of that 43%, 58% had alcohol problems, and 63% of patients accepted a referral for counseling. That's an incredibly high proportion of a random sample from emergency. So we're learning from the other studies and literature from our work that abstinent brain is a brain in recovery. In general, we could say emotional circuits appear to be inhibited and executive decision-making circuits appear to be enhanced. In the TransArc study, we've looked at short-term abstinence, and we've measured resting state fMRI. I'm going to present some preliminary data related to default mode network changes. As I said, this was an ERAnet and CIHR-funded project. We have a first MRI scan on completion of detox. These are serious drinkers. And a second MRI scan on completion of residential treatment. We wanted to make sure they were really alcohol abstinent. And we were attempting to do an open-label study of naltrexone to try and assess the effects of naltrexone. Standard screening tests, we looked at a thorough profile for psychiatric disorders. And apart from alcohol-related depression and anxiety, no other disorders were allowed in. We used male subjects, 18 to 65-year-old patients. For drinking, they had to be chronic, steady, or daily drinkers, and DSM-4-TR alcohol use disorder. Lots of exclusion criteria here. We allowed nicotine and non-recent limited cannabis abuse. We took out everything else. And we had quite severe magnetic resonance safety criteria because there's a big magnet, 4.7T. So no tattoos, no metal, no operations, and no history of metal work. Because of the very short days of abstinence, before starting the program, we had a fairly low recruitment rate for quite a lot of subjects. So here we have session 1, 6 to 12 days abstinent. They have their scan. They go into the treatment program, and they come out successfully. Second scan, 27 to 33 days. From over 1,100 patients screened, we ended up with 29 patients, and we matched that with 18 controls. Naltrexone, just as a point, we started at 50 milligrams for 3 days and then increased to 100 milligrams a day. It was well tolerated. Impressively, 10 out of 12 subjects that had naltrexone remained abstinent at 1 month, and the same subjects remained abstinent at 4 months. The unmedicated subjects, there was only 56% remaining abstinent at a month. It's an informal observation, and the literature on naltrexone is complicated these days, but it seems to be effective with the right doses. So preliminary results. We use resting state, and we've looked at a lot of different networks, but we're focusing on the default mode network, which is a predominantly subcortical and cortical midline network showing strong activity, especially in the resting state. We have data for default mode, frontal network, and frontoparietal network. These are illustrations of network activity from a paper by Martin et al. In 2010. This is default mode network, and this is default mode network from our data, different aspects shown in this slide. So looking at default mode network-related changes, patients versus controls, the blue regions here are less activity in patients compared to controls, and the red regions are more activity in patients relative to controls. And we find for the dorsomedial prefrontal cortex and the ventromedial prefrontal cortex at scan 1, very early abstinence, that patients show less activity than controls. And in the ventral anterior striatum, which is strongly implicated in craving and reward processes, we have more activity. On the second scan, we still have activity in the dorsomedial and ventromedial prefrontal cortex. The ventral anterior striatum seems to be fading, and we also get an emergence of activity greater for patients than controls in the subgenual anterior cingulate cortex, which is a very significant area around emotion, risk, and decision-making. Recent other studies have looked at longer-term abstinence, and a couple of papers by Kam Chong and colleagues from Hawaii looking at seeded analyses focusing on the default mode network with a nucleus accumbens or ventral anterior striatum seed and a subgenual anterior cingulate cortex seed, both areas that we've seen changes in. And their results generally show in the histogram, the blue bar is non-substance abuse controls, the green is short-term abstinence, and the bar on the right is long-term abstinence. And they show an increase in mean Z scores for synchrony in these abstinent patients when looking at nucleus accumbens and dorsolateral prefrontal cortex connections, and also for subgenual anterior cingulate cortex connections. The whole network approach is complex and interesting. Lehman and colleagues have shown that if you look at a resource allocation index, looking at coupling between networks, it's lower in abstinence compared with satiety states, for nicotine addiction at least. And they suggested alterations in coupling of salience and default mode networks, and the inability to disengage from default mode network may be critical for substance dependence. So summary and key points: alcohol withdrawal in the abstinent brain, recovery from addiction is obviously of extreme interest. Not many people have looked at short-term changes. Using fMRI, we're measuring changes in resting state and brain circuit connections and withdrawal. Evidence suggests that the abstinent brain is actively a brain in recovery, and we think it may be very useful to add a more refined analysis of brain correlates of risk and impulsivity to determine the relationship of these constructs to recovery and sustained abstinence. I think this is the way we're going to move to get a more refined understanding of the neuropsychological underpinnings of brain structure in dependence. Thank you very much for your attention today.